glad that you could join us for the last session of the day. So I'm going to ask our panelists if they will introduce themselves, just talk a little bit about where you're from, what your current role is, and maybe you can reflect on some things in your background, if that's appropriate. And then as you all may notice, Marie is not with us. She might be coming, but Julie is going to pitch in and comment and help us out through the last panel. So would you like to go ahead and start with us?
Happy to. So thank you. Honor to be here. Jennifer DeCabalis. I'm the CEO for Hennepin Healthcare. I have been at Hennepin Healthcare for 4.5 years now. I started 2 weeks before COVID hit. 4 months later, the murder of George Floyd, and we were the responding healthcare system, and we've been running ever since. From a background perspective, I came from Hennepin County, so really have a background in the social services and healthcare. So some of the opportunities I see, and I've heard them throughout the day, is how do we connect our worlds better, whether it's public health, which was a question earlier, whether it's mental health and addiction that is heavily covered by social services, but it's also in the medical space. So how do we align systems is really what I've been intrigued by all day long. So I look forward to the discussion.
Hi, thank you for having us. And my name is Cammie Peterson-DeVries. I am actually here with the Minnesota Organization of Registered Nurses. I am a nurse practitioner, and I'm a VP, and I oversee 14 nursing homes and 13 assisted living and 10 independent livings, including HUD. And so my background is I've always kind of gravitated towards senior services, so I always feel like I'm a pretty strong voice at times. At a legislative perspective and in other venues for our older adults. I agree. I think that we really have to look at what one of our group was saying is that we have to stop being competitors and being cooperators. And I think we have to really take down the barriers that we can and recognize that metro is different than rural, and rural health has its own disparities. So. There, I'll turn it over to you.
Hi, Julie Fallhaber, Managing Director of Medicare and Dual Eligible Programs at HMA. Been in the managed care world for about 25, almost 30 years now, and had spent 13 of those years here leading the Medicaid and Dual Eligible Programs as VP and General Manager of one of the local managed care plans prior to joining HMA. And so standing in for Marie from the managed care perspective, although she has, of course, much greater background, and hope that she'll be able to join us soon.
Great, thank you. Okay, so we have two jobs this afternoon in our final session. One is we're going to hit on some of the highlights from what we heard today, and so if you all want to share some really great things you heard in the sessions. And the second is we're really charged to talk about collaboration. And as we think about these big issues that have come up, and certainly our last panel of esteemed legislators talked about lots of things, we really want to make sure we're hitting on collaboration. So very first thing this morning, wow, that story about dialysis was fantastic this morning. I just thought, Rochelle Schultz came and talked to us about in Winona about how the issue that they're having in terms of keeping that dialysis clinic open there, and really that's a rural health issue, and thinking about how critical that service is. And at the end of the 11th hour, really somebody coming in from the community and saving that service. And also we heard from Lisa up in Lakewood, who told us about how out of her 5,000 population community, what did she say, or 3,000 population community, they had 500 births. So again, a rural area, but a young population. And so I want to start with Cammie. If you can talk to us a little about, how are you thinking about rural health care? How are you thinking about how collaboration can help some of these difficult problems, and knowing the unique landscape that you all face in Minnesota?
Okay, thank you. I think that the landscape in rural is really challenging at this time. Part of it is that the infrastructure is really deteriorating. We are seeing EMS systems not being available in our rural communities, which is really a foundation to how people get to emergency services. We are seeing rural hospitals close. Out of our 365 nursing homes a few years ago, we have had 20 nursing homes close in the last 2.5 years, and most of them have been in rural. There's a continuum of health that doesn't occur in rural Minnesota. The continuum of health doesn't include, you may have a hospital that is 35 to 40 miles away. You may not have a primary physician. You may have difficulties getting people to be medical directors in your nursing homes, being able to take care of people. It's just a really challenge. And then you look at the infrastructure of we've talked a little bit about broadband and that type of stuff, and I think broadband is great. I think we need grants to get that, but then how do you make it affordable to your most vulnerable people? Because it doesn't come without a cost. So transportation is an infrastructure that's an issue. EMS is an issue. Our local hospitals, as we've talked about, they are not doing maternity. They're not doing any of those types of services in rural communities. And it is kind of a stabilize and get out type of field right now for our emergency rooms in rural areas. And that's really not taking care of the community.
So if I could piggyback on that, I think that rural health matters to everybody. As a system that is a safety net system, we need you well. We need the other health systems well across Minnesota because we know we don't have access either. We can't take it on. And so I think when you talk about collaboration, it is how do we all lean into that problem and bring solutions, and what do those solutions look like, which needs to start with rural voices telling us what matters most and how can we lean in. And if I could just piggyback on some of the, we are a teaching hospital. So for example, when we hear that certain sites don't have an expertise, well, many of them trained at Hennepin Healthcare, and if we have a way to bring our teaching to the forefront, to bring consult, to bring assistance. EMS would be another example. We've got a paramedic program, as we heard a lot today, around workforce shortages. Well, so what we've said is nobody's going to bring the workforce. We got to find the workforce. We got to develop it. We got to create it. So we put together an EMT and a paramedic academy with the intent of saying, if we can give livable wages, pay you, if you're excited about being in healthcare and you think you want to be an EMT or a paramedic, let's bring you in, let's pay you a livable wage. 6 months, we've got you on the streets and deployed. We, for the first time ever, are fully staffed in our EMS, and we have a wait list. So now you take it to rural Minnesota, and I go, gosh, we've already figured out that training engine. If rural Minnesota could benefit and we could leverage deed funding or some other funding to help bring rural Minnesota into that training and say, gosh, we want to get them back to you. And the commitment is we're going to pay them, we're going to train them, they're going to go back to your community, and they're going to agree to serve for 3 years in a local community in that role. Those are the kind of solutions I heard throughout the day of how do we all lean in together, stop competing, start helping each other, because we're on a crash course if we don't.
You're absolutely right. Would you add
Any thoughts, Julie, on how the MA plans or the DSNP plans have been thinking about rural health?
Well, it obviously is a huge issue, and certainly here in Minnesota. And I think that both MA plans, but even more importantly, medical assistants, MCOs, have been investing heavily in rural communities and participating in innovative programs such as, workforce development, particularly around the, increasing providers in the mental health space, as well as some of the other programs that you all have been mentioning.
Fantastic. Okay, so next we had, and I did Paul's session, I think on waivers and demonstration. I heard it was standing room only in that session, and it was a really fantastic overview. I think you all mentioned about some of the great work that's happening in 1115s and about the justice-involved population and about health-related social needs. So we also heard, I went to the gun violence session, and so thinking about health-related social needs and social drivers of health, again, not just employment, not just education, not just food insecurity, but some of the ones that have come up today, childcare. That one was really fantastic. We heard about climate issues and community violence. So again, that came up in our public health session. So want to hear from you all. What are your thoughts about, again, how can we, obviously Medicaid can be a driver here because the 1115, that gives us fantastic access and allows us to pay for services we haven't been able to before. But in addition to Medicaid, what are those key collaborations that really need to happen, not just with the community-based organizations, but how can the business community get involved? How can we get involved with payers, providers? And so, Jennifer, if you want to go first this time, that'd be fantastic.
Sure. I think, so we've talked a lot about systems of care, and it is healthy communities are thriving communities. It doesn't matter, rural, urban, where you are. And our businesses have employees that need to be healthy. Our community has neighbors that need to be healthy. So it is everybody's business. And I think what we've talked a lot about is what role can all of us play. So you might be in long-term care. I might have acute care. However, I need you. You need us. And so how do we all play our role and leverage each other? And what we're talking a lot about right now is how do we create systems of care? I think the days of vertical, everybody does everything for everyone are gone. We're competing against each other. We're competing on salaries. We're raising rates. We're putting each other out of business. It is the what role can I play? What can I bring to the table? Let's align the funding, let's align the opportunities, and truly create a system that makes staying healthy, getting healthy, being healthy easier for everybody. And I think we heard that in the waiver conversation about the justice-involved population, and I think of it as smart government and smart spending. So if we're spending a lot of time incarcerating and a lot of money incarcerating people, and we believe addiction is driving them there, then how do we make sure that the addiction services are available to support individuals so that they avoid that? So I'm a firm believer that we have enough money in Medicaid. Where that money is being spent is the problem. So how do we simplify and create the system? And that will take all of us saying, what pocket is it in? Where does it need to be? What expertise can we bring to the table, and how do we move together?
I would agree. I agree. And I think that it is about that open dialogue to say what services are our expertise and what is it and how do we collaborate together and how do we let go of some of our ego around some of the things that maybe we're not the best provider for. So how do we best use those dollars to really impact the greater good? And it does mean, from my perspective, it really does mean a real different alignment of resources and looking at it and saying everybody is needed. Every service that we provide is needed. There are things that we heard today that some of us weren't even aware of that maybe another organization is doing something very similarly. How do we take those similar dollars and use them, as you said, use them to really broaden and really streamline things so that we don't have all the duplication of services for many organizations? How do we just embrace them and make them an organization where each one can really serve people and not duplicate?
And I would use a concrete example. We have daily huddles, and a lot of healthcare systems do, where across the organization we have a daily huddle, and we look at what the demand is. What is our community need from us today? We are typically a 400-bed hospital. Yesterday, sorry, my numbers are a day old. Yesterday was 420. We're a 400-bed hospital. We had 420 heads and beds. We have a 66-bed emergency department. 66 beds. We had 96 people in the emergency department. We had 45 people in our 400 beds, that's over 10%, who didn't need to be there. They needed your care, they needed behavioral health, they needed case management, they needed guardianship, but they didn't need to be there. That tells you the huge opportunity when we're spending time, energy, our workforce is working incredibly hard like everybody's is, and it's the wrong energy. It's how do we get people in the right spot? And that is going to take all of us not just to reform, but to transform how healthcare works in Minnesota. And I am grateful for our legislators that are here today, but I don't think it's their job to figure it out. I think it's the brains that I saw in all of those breakouts to get together for us to say, so what does that look like? How do we hand them what the future of healthcare should look like across Minnesota? We've done it before, and I believe we can do it again.
Fantastic. Cami, I want to ask you one more question. So Susan McGeehan had her session that was on aging, transformation of aging, and Wow. I mean, this multi-sector blueprint on aging, I think I said all of that correctly. I heard something about 9 different agencies coming together to collaborate, and obviously with advocates as well and providers. And so when you think about social determinants of health and housing in particular for the aging population, what are some thoughts that you have on that, or ideas that you've seen, best practices? Anything there that you think would be helpful for us all to think about?
Well, I think that there's been some challenges with housing with our aging population. And some of it is that we've set up systems to actually assist people, like assisted living or nursing homes or any of that. And some of it has become unaffordable. And there isn't a lot of HUD. The way HUD works is there isn't a lot of times that you can have supportive services that are directly involved in HUD. So you end up with some areas that are really a gap in services, and people are going to want to stay then in their homes. Now having people with aging wanting to stay in their homes is not a bad thing, but our structure does not support that. We saw a cut around Meals on Wheels programs over the last several years. We see that transportation is a problem for people to get around. Equipment, having our older adults have equipment or things to make their homes safe for them to be home. Their structure isn't there to support that. So I think that it is around housing. We have to kind of look at where do people want to live? Can they afford it? And how do we support them in living their best life in that environment?
And as we've seen, MA plans compete off of some of these issues, right? So supplemental benefits that are provided, not just silver sneakers, but now we're looking at things that can address SDOH issues as well. And now there'll be more reporting, I think, on what's in those supplemental benefits. There's going to be some more requirements there. But I do think that is something that we've seen MA plans compete off of, particularly in the dual eligible space. Julie, do you think that are we sort of at the early stages of seeing the MA plans and the DSNP plans start to address those issues? Do we see pockets where they're making really good progress? Any thoughts on how MA can work as aligned with Medicaid as well?
Well, of course, here in Minnesota, you have a great program for the DSNPs. The MSHO program has been nationally recognized as one of the nation-leading programs for dual eligible beneficiaries. So and that was born out in the early 2000s and actually in the 90s of great collaboration amongst payers, providers, the state and federal government. And so building on that, here you're in a very unique, mature market situation with your DSNPs of being able to leverage the MLTSS services as well as supplemental benefits that have been quite rich and those that are impacting social determinants of health. And so looking at collaborations around housing and other types of supplemental benefits has been something that those programs have done for a long time.
Fantastic. So you all have a lot to offer up as lessons learned to the rest of us as well. So fantastic. Okay, so we also had a session on children's issues. We talked about access. There were discussions about movement towards universal coverage, and also one of the issues that at least we see so many states talking about now, children's behavioral health. And a lot of great information. We had someone from the Children's Cabinet, someone from Carillon there, Leap Pediatric, Minnesota Association of Children's Mental Health. So again, we know this issue of behavioral health for children has just exacerbated since we've come out of COVID. And not only children, but also parents. Someone referenced this morning the Surgeon General report that just came out about parents and parents dealing with issues as well. And so want to ask you all, maybe Jennifer, if you can start thinking about children and children's behavioral health. Again, what do you think the opportunities there are in terms of the state? Do you see focus in that area? Do we see more opportunities where we can pivot in that area? And maybe some things that you all are thinking about that are top of mind for you in this area of children's behavioral health.
Absolutely. I think of, as a mom, I think of my 3 kids, and there's nothing more important. You're as happy as your least happy child on any given day. So you think of the stress of parenting, and this is our future. These young people are the future. They are the ones that will take care of us as we're aging. And I think that what we're seeing is that there is a tremendous need for supports, and it's not in hospitals. It really is in the community. It is prevention. It is early intervention. It is getting ahead of it and making sure families have the services and supports they need. I looked back recently at just our past 12 months. We've had 100 kids in our emergency department, that's just one emergency department, that had no reason to be there. And those kids stayed on average 46 days. That, as a parent, is heartbreaking. And it was not the parent. It was parents, caregivers, guardians that said, I've tried everything and I don't have the support I need to keep them safe. And so I'm desperate. So I'm bringing them to you. Well, I can tell you our emergency department as a Trauma One hospital is incredible, but it is not the place to raise a child. So what we have heard in looking at all of those cases and what we have seen is, had we been able to deploy in-home supports that provided hands-on training, hands-on, how do I regulate behaviors when things feel out of control? How do we train parents and our entire community to help kids when they're struggling, and how do we make those easily accessible, is the game changer from somebody making that heart-wrenching decision to say, I've got to abandon my parental rights because I've run out of options. And I think that's a huge investment that we could all get around, is what does that training, that in-home support, let parents be parents, but let's help them get through when they need help the most, is critical.
And I imagine Representative Fisher, Senator Fisher? There we go, I got it. So I imagine that's also what you were talking about, those wraparound services as well in the community. We also heard Will Wallace talk this morning about cohorts that they've been training of inner city youth to really focus on this disruption of violence within the family. And so I imagine that you all, a big wish is for more of those community services to be available to you. Are there programs that you work with that you wish, and also I think Sarah Kenny talked about think big, act small, scale faster. So any ideas for programs that you've seen that we should scale this really works? Any thoughts on that?
Not seeing anyone jump in. So we've had some conversations around some training that really is about de-escalation training. And I go, gosh, there are some incredible outcomes with a couple of programs that are national training programs for de-escalation. And you go, gosh, if every school had it, if families had it, if communities had it, if we got this spread across Minnesota, it would equip all of us. I think that's one. I think what a lot of schools are doing, we had a great conversation last night that was about dysregulation, when a child is feeling dysregulated, and actually seeing some real bright spots of our young people starting to go, oh, Mom, you might be emotionally reacting. Maybe you should just take a breather for a minute. I love that, because that tells me there's some hope. That how do we spread that type of learning and education through all of our schools, through all of our communities? And so I think training is a huge opportunity for us as a state.
And Cammie and Julie, maybe to shift and think about behavioral health in the aging population. I know that we struggle quite a bit in North Dakota thinking about, in our nursing facilities and in our home and community-based services, do we have the staff that can provide that really intensive behavioral health services that are needed? So, Cammie, can you talk a little bit about maybe the needs that you see in the community, the opportunities for collaboration, specifically around behavioral health for our aging population?
Yeah, I would also say that, just like Jennifer talked, we are really not fulfilling the needs of our behavioral health in children or in the aging population. If we have, and we've had this situation in one of our assisted livings that was in dementia care, we had a gentleman that started to have some behavior issues, and we had to do one-on-one for 45 days until they could find a placement to where they would be safe, because other people weren't safe. And it's not, there isn't the adult behavior health, I think, up in the Staples area, Lakewood, I think, actually has an adult behavioral health unit. But it's a very specialized, right, because medications work differently on our elders, and things work differently for our elder, and they have more special needs. And so in just an adult behavioral unit that isn't also a potential med-surg unit is going to have a challenge taking care of our older adults if they're having mental health crisis. So I think that adding more mental health practitioners, I do think that telehealth with mental health is going to be helpful. I do agree with Jennifer that if we can have some education, I think about staff education in employers, people that are working with that too, of just being able to offer those kind of education so that we recognize it sooner, that we reach out into a telehealth. But even right now, telehealth is a challenge in rural areas too. So, but I do think there's some opportunities for us to increase telehealth, to increase access, to provide maybe some specialty areas that actually work with older adults with behavior disturbances going on.
And I think those are the adults that I think I worry about sometimes the most, because they're most likely to fall through the cracks. So if you think about if we have a continuum of care in the community that doesn't have enough capacity, and I'm aging or an individual with disabilities and I've got behaviors that are coming along with that, the likelihood of them getting that spot is slim to none. When I talk about 45 people sitting, those are the 45 people sitting in a hospital bed, living there for years. And so I do think there's some solutions as a state to say, if we're paying for everybody at the same rate, and we know there's some people with the highest vulnerabilities that need to get to the front of the line, do we have to pay differently? Is there a complexity payment? Just like in the hospital, we have case index. We have, depending on your acuity, our rates change. Do we need to extend that into the public continuum that's out in the community so that more people are jumping into that space and saying, I got this population? I would also throw out the courts. I had 2 gentlemen, 55 years old, early onset dementia, live in our hospital over 8 months, just waiting for a court hearing for guardianship so somebody could consent to their placement. It's a misuse of acute care. So those are opportunities where I go, Minnesota, we're paying for the highest level of care, tying up a bed, and we can get smarter about how do we fast track some of that to get people to the care that they need.
Correct.
And speaking about perhaps not as robust of cases as you were discussing, but just I think managed care has noticed, of course, the behavioral health concerns and have done things like, in addition to the telehealth components that you were talking about, pre-purchasing appointments, having appointment availability when there is workforce available, right? To be able to supplement with the telehealth, but to be able to pre-purchase appointments so they have those available for when individuals need care, to be able to get them in quickly for services. And so that's one methodology to help, but of course it's a whole system-wide issue, and these other options are great as well.
Are there ways, I'm curious, in those pre-purchased appointments, are there ways that we watch for equity in that so that we're not, again, I watch for the
Yes,
privilege and those with funding and those with money,
Right.
maybe getting to the front of the line, and is there a
These
risk
have been
of that?
occurring in the medical assistance programs, but there's still the concern, right, that you're talking about. So even if it's individuals with low income, are they being given to the most vocal? Is it their care managers the most vocal? Is it the person that needs the best, has the most need? And I think that those are all legitimate concerns that we're trying to address.
We talked about some opportunities you had mentioned the session on the 1115 waivers, and one thing that was raised there is the number of case managers, and that's what made me think about that session. So it's not uncommon for individuals in our community to have 5 case managers. So you think about the opportunity we have if they've got somebody maybe for mental health, maybe for aging, maybe somebody that's helping them with housing, maybe somebody at the county, maybe a social worker that's trying to prevent a rehospitalization. There's some significant opportunities for us to simplify the system and then redeploy those other 4 case managers to help take care of somebody else. Because we're so program and funding specific in our state, we've got to create some flexibility to take care of people and less about putting people into programs.
And I think we also have to just remember that any kind of behavioral health issues jeopardizes housing, whether it is their own home, whether it is institutional, whatever that is, their housing becomes jeopardized due to the mental health problems or behavioral issues. So I think that looking at what we really can do to help address those and figure that out would be really beneficial to our state.
I've been working Medicaid for almost 25 years, and one of my questions has always been to vendors, give me a solution to coordinate my care coordination. And it's that multiple levels of care coordination, multiple IT systems that we use. So your point is well taken. So last question, then we're going to invite you all from the audience to join the discussion. So obviously great ideas, lots of opportunities here. It all really boils down to the capacity of the workforce to implement and execute these, right? And so we've heard discussion today about workforce and workforce issues and how you all are thinking about this in Minnesota. And particularly about young families, getting young families to come, to stay, and thinking about how we recruit and retain. And we've seen lots of dollars being invested as part of the ARPA funds being invested in HCBS. For example, we've heard a lot of discussion about direct care workers and about raising minimum wage in other states and recruitment and retention. So I want to ask you from your perspective where you sit, thinking about workforce, where are your concerns? And maybe how are you thinking about approaching some of those concerns, or maybe some really creative things that you've seen or heard around the state? So who wants to take that one first?
I could probably
Okay,
take that.
perfect.
So I think that we have to remember that we have to take care of the whole person. That I said to my team pretty frequently, okay, remember our generations coming in don't look at work as we do. We have to look at what is it that they really need. And so we've tried some innovative things in our organization. One of the things, we do have several of our buildings that do have a child care on site, that we offer some child care. We have some of our sites that actually have kind of an informal food shelf where people bring things in and people can take to do some of that. We also use some of the leftovers that are done in that, and people can buy for $1 and take home a couple of meals home. And then as an administrator, I had to bring your kids to work, because in rural Minnesota, when your one daycare shuts down for the day because something's going wrong and the daycare worker you have 6 people who can't come to work. And so we developed a Bring Your Kids to Work program and actually have buses that come and drop kids off and pick them up. So there are ways that we can take care of the whole people, the whole person in our workplace. I think it helps. It's not all. You know, people still need a workable wage, a livable wage, and that type of stuff. But it's certainly how we can support them as a whole person, including their own mental health and their own kids' mental health, because it all goes together so that they can bring their best self to work.
I would add to that, just like we talk about what matters most to our patients, what do they need? What matters most to our team members is certainly important. It's safety, it's flexibility, it's I want to feel seen, valued, heard. I want some maybe diversity in my day because it gets exhausting to do the same thing. And so how do we take care of the workforce? Some of the things we've started doing is on demand. We've got an app on demand. Think of our paramedics who are out handling trauma after trauma after trauma, and those calls are coming in. And the ability for them to pull over a rig, get a quick checkup from the head up to say, I need to debrief with somebody about what I just saw, what I just went through. Clock out for a minute, get back on the road when they're able to. So I think all of those are investments. I also think as healthcare, we need to stop talking about how darn hard healthcare is and about all this burnout. Because if I'm a young person, I don't want to jump into what's really hard and what's burnt out. When I have bad days, I walk our units, I go to our clinics, I ride our rigs. And it inspires me every single time because people are doing incredible caregiving and incredible work. And so how do we inspire? We have a talent garden program that is about 12 to 18-year-olds that come in. We've now touched 800 young people from marginalized, underserved communities and gotten them into healthcare. And those 800, then we have internships, they can do mentoring. It is so much fun to have them come in, and at the beginning they're pretty shy, they're pretty meek, not really sure where they want, but they know they like something about healthcare. And the excitement, I stood next to a mom who was nervous and she said, "Jennifer, I'm pretty sure my kid is sitting in the corner of your hospital somewhere and has been there all day." And I said, "I'll stand with you. Let's wait until he comes down." Well, all of a sudden her face brightened up and I looked up and there was a kid running down the stairs towards her, and he came running up and he goes, "Mom, I'm going to be a facial reconstructive surgeon." I looked at her and I said, "I think your kid had a pretty darn good day. I think we got him." Those young people are our future. They are inspiring, and the best thing we can do is make sure how we're talking about healthcare and how we're showing them how healthcare shows up, that we're getting them excited. We have hired some of those young people. Some of those young people are already in medical school. We are creating excitement and interest, and I think there's opportunities like that across the entire state, that if we started talking more and collaborating about what are people doing, I'm actually really encouraged. We've got an incredible workforce coming forward.
Well, we'll go ahead, and to your point, in rural North Dakota, there's one county that will let my daughter, who's 17, ride on the ambulance now, and I'm so excited. It's just fantastic to involve young people in those, in our profession. So we're going to go ahead and we got a couple minutes left. Think about questions, anything burning, anything you've heard today that you want more elaboration on. Oh, I see walking that way, and we've got one here too.
Yes, what are the biggest problems and opportunities in data?
Oh, we didn't hear the question. Can you repeat the question?
The biggest problems and opportunities in data, healthcare data?
Sure. Any comments on the data? Lack of data, I'm assuming, lack of interoperability of the data.
I think that we all find that we have a lot of data at our fingertips. I think it's always about how useful it is and what we do with it, because we can get a lot of information at a few strokes on our computers. And is the data valuable? And are we spending resources on the appropriate data to collect? And so I think that even in our environment, we end up with a lot of data, but we don't always use it to really inform and make better decisions. It becomes actionable, right? It becomes a data dump of, oh, this is the data that we're seeing, and oh, bad, we didn't do very good in this, and we don't really take it and go, okay, what is this telling us? And I think that we have opportunities to take our data. Minnesota does a lot of data collection on their own around health outcomes on various industries, from our nursing homes and all that. I think it's important to look at it, to ask the key questions, and then to ask more questions, and then use it for action.
And one opportunity coming up that DHS will have is we have a final rule now that's about interoperability of data around prior authorization. And so you at the legislature as well, there'll be a reporting process around prior authorization that will now be standardized across the managed care organizations, and we'll be able to digest that data and have data that's reportable and comparable. And so that'll be coming up, I believe it's in 2026. But I think you all are ahead of the curve in terms of thinking about prior authorization and how to standardize that.
I know there was a session today, and Dr. Winkleman is probably still in the room. There is a collaboration that already exists across health systems, voluntarily sharing data with privacy protections in place, where we can pull and see where do we need to focus, why do we need to focus. It was a database that was instrumental, for example, when we put out the vaccines during COVID, and we were able to see who needs them most. Are they getting to the front of the line? They weren't, and we were able to deploy appropriately because we could see that in the data. So data is available now. It's not perfect, but we can't wait for perfect. I think we can get action, as Sarah mentioned, think big, act small, scale fast. Let's leverage the information that we do have at our fingertips, and some of that is asking questions. The state has incredible data that they collect, at least for people on public programs. So do counties, and so it's us asking the questions and making sure we can get the best answers we have today and then focus on those outcomes going forward.
I was just going to say, Minnesota is very unique in its collaboration in between its managed care organizations, and they have their own data group, voluntary, to submit data to look for outcomes as well. And so that's been long-standing, and there's a lot of information there to be able to be used to improve outcomes.
Okay, so we're going to ask Kathleen to come up and talk us through the last set of instructions. But first of all, I want you all to please give our panel a round of applause, especially Julie. We appreciate you standing in. Fantastic. And we'll ask Kathleen to close this out.